in welcoming you this afternoon. We have a real treat in store for you, thanks to 3 of our post-acute coordinators. And I will tell you that we are doing this as a series. This is such an important webinar. We started out just by nature of when the waves fell on the calendar. We had Wave 3 webinar on Tuesday, and our lead principal investigator, Dr. Pam Duncan, who many of you, most of you probably have met by now, listened in on that webinar, and she was overjoyed by the outstanding job that our 3 post-acute coordinators that you're going to hear momentarily did. And she shared the webinar link on our steering committee this morning, and she said she doesn't normally give our steering committee members assignments, but she gave them assignments to everyone. Listen and watch the video between now and our meeting next Thursday. So that's how important we feel this webinar is for providing you all strategies for helping you get closer and closer to what we are now calling our stretch goal in the COMPASS team, and you're going to be calling it that too. We know that we would like to have all of our patients get back to their 7 to 14-day clinic visits. That would be in the ideal world. But in the real world, they deal with many competing priorities and some barriers that you all are hearing about and addressing. But we do have 3 of our sites that are meeting that stretch goal, and they are so gracious as to share their journey with getting there and their plans for moving forward. And we're just very grateful to them for that. We have also, in addition, after the webinar today, we will share with you the slide set so you can share it with your team. After we have the 3rd webinar, which will be for Wave 2, next Tuesday, the 28th, we will be posting the webinar actually on our website, so you can refer your team members to it as you feel will be beneficial. We also will be sending out later today a tips or helpful hints sheet that is, it's a 1-pager that you can keep as a cheat sheet with you to use as you feel will be helpful. And it's a summary of the 3 presentations today boiled down onto 1 sheet of paper. And from there, what I'm going to do is I'm taking notes from the examples that are given on all 3 webinars, as well as any discussion, and I'm going to boil that down for you into some motivational coaching scripting that we will be sending out a little bit later that you all can use all the way starting from before you discharge the patient from the hospital all the way through the 2-day call, getting the patients back to that 7 to 14-day visit, and getting them that care plan that we know is so valuable to them in helping them find their way forward to recovery, independence, and health. What we're all here today and what we're all in our jobs, to be all about. So I want to give plenty of time for our 3 presenters to talk to you about strategies to facilitate return to the COMPASS visit and receipt of the eCare plan. And we're going to go in the order in which the waves are falling. You'll see on your agenda. We're going to have, even though Sarah Day is out today due to her son's illness, we have recorded her presentation, and she did a great job with the recording. So we'll have Sarah go first, and we are privileged to have Emily Parks with us today, who can answer any questions you might have on Hugh Chatham Memorial Hospital's presentation. And then we'll have Melissa Hanrahan, Wave 2 from Mission Hospital will present, and then we will have Whitney Arrington from Wave 3 from Fry Regional Medical Center. So we have 3 different kinds of hospitals as far as size, small, medium, and larger. And then we have rural and more metropolitan. So again, we're just trying to look at strategies that will work This is a pragmatic study meant to work in sites all across North Carolina and beyond. So they're going to talk with you about where they were when they started the COMPASS model, their assessments of where they needed to head, and the strategies that they used to get to where they are today with meeting that stretch goal. So Rika, I'm going to turn back over to you to play the webinar for Hugh Chatham.
All right, perfect.
Hi, this is Sarah Day. I am a registered nurse here at Hugh Chatham Memorial Hospital. I'm the post-acute coordinator with the Wave 1 team. Today I want to discuss the challenges and successes with implementation of the COMPASS model here at Hugh Chatham. This is just a brief introduction to our facility here. We have 81 inpatient beds, 24 emergency room beds. Usually in a year we see around 275 to 300 stroke or TIA discharges. Typically 65 to 70% of those are discharged home. And here in our area we have one outpatient neurology practice, and we have one physician at that practice and one PA. During the COMPASS launch, we faced some challenges. There's 4 listed here. Probably the biggest challenge was capturing eligible patients. During the first week, I think we actually missed 2 or 3 patients, and so we quickly learned that we needed to implement some things that people would be reminded to contact me prior to the TIA and stroke patients going home, because, you know, this was a new intervention for us. So the first thing we did to our discharge order set was we added call post-acute coordinator prior to discharge. So when the hospital has discharged the stroke and TIA patients and they use their order set, this automatically comes up under the physician orders for the nurses to do. The next thing we did so that would take place was that we had to educate the managers on the units and the team leaders, both on the medical unit and the ICU. We also had to in the ED because we found out that we were having some TIA patients discharged directly out of the emergency department. That's unusual. We typically hold them for 24 hours for observation, but for the ones that are discharged out of the ED, we had to educate the ED coordinators and team leaders in that department to contact me prior to discharge. Also, when we had our community meeting here at the hospital, we invited a case manager to join our team, our meeting. So she's very engaged in this program and knows the importance of the COMPASS model. She's also here and calls me for TIA and stroke patients if there are some on the floor that she thinks I need to probably look at. I also get a core measure report every morning, so that may include, you know, congestive heart failure patients and stuff like that too, but that's a pretty good way to capture stroke and TIA patients. I attend morning rounds. It's a multidisciplinary meeting among different specialties, physical therapy, nutrition, the physician. This is a good place for me to question the physician as to whether the discharge diagnosis is going to be TIA or stroke. It's also a good time. Our home health team is also represented there, and it's a good time for us to talk about whether the patient needs home health, physical therapy, or, you know, maybe they need outpatient treatment or something like that. There's also a pharmacist at the meeting, which is a good thing to discuss, you know, aspirin therapy and things like that they might need at discharge. The second challenge we faced was the 2-day follow-up phone call. We didn't have a whole lot of problem with this. The main thing we found was that it's really important to meet the patient in person, because that way you can verify that their number is correct. Often, you know, the stuff listed in our system may be years old and may not have been updated when the patient came in. And so that's an important aspect of that, the 2-day follow-up call. The third challenge was the 7 to 14-day clinic visit. Like I mentioned earlier, we only have one neurology clinic in our area. The PA at that clinic, Bill Jarrett, is actually our APP. So what we did to make sure that their schedule was available was he cleared his Tuesday and Wednesday afternoon after lunch. That way I could make sure I always had space to put COMPASS patients. They also gave me access to their schedule so that I can just go in and directly schedule the patients and not have to bother the office staff over there. I'll always schedule their appointments before they're discharged, put it on an appointment card for them, and talk to them about it before they leave to make sure it's something that they will be able to attend, that there's no conflicts in their schedule. I also call them, especially if it's, if it's 3 or 4 days after discharge, we don't, but if it's, a couple of weeks after discharge, we call 1 to 2 days before to remind them that they have an appointment. Sometimes I do this. Sometimes some of the office staff over there does because that's just what they do. That's just part of their routine is they call patients to remind them of their appointments. The other thing, we schedule patients as soon as possible after hospitalization. So usually it will be within 4 or 5 days of discharge. This is helpful if the patient needs to reschedule because a lot of times you can still get them in within 14 days. We've had this happen a couple of times. They were scheduled 5 days out and needed to cancel, but we were still able to get them in within 2 weeks of discharge. And then again, discussing with the patient in person, the importance of follow-up is very important. Another challenge that we faced in the beginning was backup PAC and APP. For myself, we have 2 people that are my backup, the stroke and education coordinator and the director of healthcare improvement. Both back me up if needed, and they did go to the Compass Boot Camp so that they could be familiar with the process. We do not have a backup APP, but our APP is very good to arrange the schedule for availability for me. He went on vacation actually a few weeks ago, but still managed to see all the patients that we needed to meet the 14-day mark. This is just a comparison of the enrollment process as far as weekday compared to weekend. So during the weekday, as I mentioned earlier, I receive a core measure report every morning that has the stroke and TIA patients on there. I usually look over these charts and then go to multidisciplinary rounds. That way I can discuss again with the physician, is this somebody that's possibly a TIA, whatever they need, as far as therapy and outpatient treatment and those kind of things. I then visit the patient prior to them going home, give them their folder, schedule their appointment, explain the importance of Compass, get a telephone number, and then I also tell them when to expect a call from me. So if they go home on Wednesday, I usually say, I'm going to call you Friday. It will probably be Friday morning. Are you going to be available? And that also helps for them to know when you're going to call them. The weekend's a little bit different because I'm not here. I do still receive the core measure report at home, or I'll receive it via email so I can see it at home, or Monday morning when I come in. And this way I can call the patient on Monday that have been discharged over the weekend and can enroll them over the phone. We also have a really good weekend case manager, and she emails me every Sunday afternoon to let me know if there's been any stroke or TIA patients discharged over the weekend. So on Mondays, when I return to the office, I review the record, I call the patient, enroll them over the phone, then I mail them their folder. I also make their follow-up appointments while we're on the phone so that they know when it is, and I send them an appointment card in the mail. These are just some tips for enrollment success. Again, the face-to-face encounter is so important because the compliance is just better. You can get the phone number, you can tell them when you're going to call, you can find out when is the best time for them to come to clinic. And I think a lot of times just putting a face to a name, it's just easier to make that connection in person rather than on the telephone. Another thing I think has been very important for us, and something that's worked really well, is involving a case manager as part of our core Compass team. The case management team here is awesome. They're the ones that set up home health, PT, nutrition services, that kind of thing. And so having them come to me and let me know what patients need has been very helpful. To improve enrollment, information gathering, verify phone number, we talked about that. I also wanted to mention our NIH stroke scale. That is part of our stroke and TIA policy and admission order set criteria. I know that's a question when you're enrolling patients is what their NIH stroke skill score was, and that's been very helpful to us is that that's a policy that you get that on admission and a discharge. Tips for 7 to 14-day clinic visits. One thing that's helped us with compliance in clinic is definitely calling the patients 24 to 48 hours prior to their appointment just to remind them to come. Also, when we do this, we find out if they can't come or maybe they've forgotten and they need to reschedule, we can also do that at that time. Again, we try to schedule them within 7 days, so if the appointment needs to be rescheduled, we can still get it within 14 days. And then we have the dedicated clinic time that are only for Compass patients. One thing we found out in the beginning with that was, when the patients weren't showing up, then our ACP was concerned because he didn't have patients that afternoon. So we have started overscheduling a little bit and putting 1 or 2 patients. Typically we start at 1 o'clock, so we'll put 1 or 2 follow-up patients at 1 o'clock. So while I'm in with the first Compass patient, he still has a couple of patients to see. Also, while I'm in the room with them at the office visit, I go ahead and obtain the consent form, explain that to them, and get that while I'm in case they leave prior to me seeing them again. Tips for the 30 to 60-day phone call. I usually remind the patient at clinic when I'm going to call them again. So if it was 14 days out, I'd say, hey, I'm going to call you again in 2 weeks. And then while we're on the phone for the 30-day call, I always remind them, I'm going to call you in another month. That's when you'll hear from me again. And thank you. There's my email. Please feel free to email me with any questions that you may have. It's shday@qchatham.org. This is Sarah J.
Okay, if there is a burning question, we can take it now while we have Emily on. Otherwise, we're going to get through the 3 presentations and then we'll have time for discussion. On Tuesday, we started taking questions in between and we started running short on time. Is there anything that's burning? Otherwise, I'm going to turn it over to Melissa Hanrahan from Mission Hospital to lead us in the next presentation. Hey, Melissa.
Hey, I guess I'll go ahead and get started. I am Melissa Hanrahan. I am one of the PACs here at Mission Hospital. I'm trying to see if it's going to let me do it. There we go. So for startup, some of the challenges we faced over the beginning was the as was already mentioned, is coming up with how do we find our patients. I think a lot of us have ways of knowing what patients are here, but finding what patients are in the ED, finding what patients are here over the weekend, those were some of the challenges that we had to overcome. What space was very limited. We have a neurology office that's outside of the hospital that is a part of Mission Health System. It's a very busy office with very limited space. They're constantly trying to come up with new ways to utilize their space better. So of course, when we approached them asking to utilize some of their space, they were excited about the Compass program, but not quite sure where to put us. So we had to do a lot of maneuvering and deciding how we can open up some office space to allow us to have this follow-up clinic. Some of the other difficulties were training of myself and our nurse practitioner on the new EMR. We are both inpatient hospital employees, so we had to learn our outpatient medical record along with learning the Compass registry. And then scheduling, initially it was taking longer than 60 minutes. We kind of prepared for that and ran a couple kind of mock patients before we got started to see how quickly we could get through the questions. We only scheduled a few patients the first week just to make sure in case we went over. But now we are getting easily seeing our patients in less than 60 minutes. Follow-up care was an issue also. As I said, our original nurse practitioner was inpatient, so when patients were calling me with follow-up care or questions or concerns, if it was something that I needed a provider for, that APP was not available 24/7. So we had to come up with some ways of being able to contact other neurologists to be able to and get their acceptance of being able to review a chart and answer my questions as needed. Getting the patient to the clinic, as you've already heard, but first to get them there, you have to know they're in your hospital. So we utilized some new ways. I have order sets. We have all of our order sets, our stroke patients. Our physicians are pretty good at utilizing the neurology stroke admission order sets when they believe the diagnosis is stroke. So off those order sets, I had already been getting a task list or list of patients, so no matter where they are in my hospital, I knew about them. What I didn't know about was patients that were in the ED and patients, over the weekend. It was very difficult to keep up with that list for patients on the weekends. Other hospitals, you'll note, utilize care management teams. Our care management team here is extremely busy and have large patient loads. So we didn't feel it was on the weekend. There's less of them on the weekends, and they're covering sometimes 3 and 4 units. So we did not feel it was a viable option for us to utilize our case manager for the weekends. But what we ended up coming up with was having a way, working with our Cerner IT folks and nursing informatics, to get a list generated. So anybody who is discharged from the ED with any type of stroke diagnosis, we get an email. So whether it's weekday, night, or weekend, we know that they've left the emergency room, and that way we're able to follow up with them soon, very quickly, usually within the next day. And then if patients that were in our regular units, and on the weekends, we would get an email that the patient has discharged. So we worked it not only so we would know the patient was here if we were not around, but we also have it linked to their discharge order, so that if we're busy, as we all wear so many hats, if we're busy doing other things and in meetings, we actually get an email ping saying that a stroke patient is getting discharged, which usually means we've got about an hour's time to get to them before they're leaving the building. So that way we weren't missing patients and weren't before they discharge and leave. And that leads right into how to get patients to come to the appointment, as was already mentioned by Shelley, is getting to meet them prior to discharge. I believe actually having that face-to-face meeting with them is a huge way to encourage them to come to your appointments and start building that relationship with them. They also get to realize they're the one that's going to be talking to you, then you're going to do follow-up phone calls, and they really seem to enjoy that. So meeting the patient prior to discharge, discussing the importance of that 7 to 14-day visit, and then during your follow-up phone call, verifying that they have transportation. One thing we found out that some of our patients were telling us that, oh yes, my daughter or a friend was going to be driving me there. And then after several no-shows, we started contacting them again, trying to find out why they didn't come. And we realized it was because they said the daughter would drive them, but their memory was maybe not as good, and they never asked the daughter to drive them. So we started actually calling whoever was going to be taking the patient to the appointment and verifying that they knew the date and time and that they were agreeing to get the patient to the appointment. And then we started utilizing, like as was said, callbacks about 24 hours, usually the day before the visit. And same thing, if we can get patients scheduled closer to that 7-day visit, if they have to reschedule, then we can still hopefully get them in within that 14-day time slot. So we're calling them prior, making sure they remember the appointment, that they still have transportation, and that is continuing to lessen our no-show rate, which is the office is quite pleased about. And then offering to change times, as when you're calling them that day before, that gives you that opportunity to say, well, what if we reschedule you to a morning or an afternoon or next week? And then if you, instead of just being a no-show without any follow-up, we're making sure we have that higher success rate of actually getting them into the clinic. So travel area is always a barrier for us. Mission Hospital does serve 18 counties. So like I said, really discussing it with the caregiver, and even in the room, making sure that those caregivers, we found that if we ask the patient that lives maybe an hour away, are they willing to come back, they typically would say no. And we feel that was, they didn't want to be an extra burden to their caregiver or their family. And that if once we involved family, the people who would actually be traveling and driving them, they actually were very willing and encouraging the stroke survivor to come back to the appointment. So getting them involved and making sure that that the patient knows that they have family that is absolutely willing to drive them and get them back to the appointment. We started off with our schedule just having every Thursday. We have 6 patients every Thursday that we were seeing, and we were noticing we were needing actually extra slots. So now we're running 2 APPs going usually at least for half the day. So we're having 6 patient load, and then having another 3 or so patients with another APP, kind of like a half-day clinic, in order to meet our 7 to 14-day window. And then having sometimes, typically it's just been 1 day a week, but now we're opening up a few slots either Thursday or Friday, and that's been helping the patients. If they have a variety of times to be able to come, they're more willing to come. And then we found that utilizing transportation companies such as Mountain Mobility, if there's a certain distance that they had to travel, they had to leave their home by certain times so that they would be back at certain times. So we could not schedule them late in the afternoon. Those patients had to be scheduled in the morning hours. So training backup, we realized very soon that Mission Hospital here, I began starting it, me and one of the nurse practitioners as the PAC and APP. We were able to hire another coordinator who has become the full-time Compass PAC, and I'm now her backup. And then we were able to get one of the outpatient nurse practitioners to agree to 1 day a week. So she's now the full-time APP with our inpatient NP who started as the backup, and then sometimes running those half-day clinics. So we definitely realized quickly, because of sickness, vacation, and other things, that you really do need that backup. And then as far as being a health system, Mission Hospital does have 5 other hospitals, smaller hospitals in our health system. One of those hospitals is also a Compass, is running the Compass program, and they did not have the personnel to provide that backup. So we worked together and worked with Compass, and we're actually, I'm able to fit in my schedule for her vacation time. So I'm actually going to be the backup for the Angel PAC while she's gone. So just kind of thinking outside the box and thinking of different ways and different possibilities that you can make sure that the program continues without any lagging, without any missed patients. The eCare plan is, once we kind of got a good flow going, I think everybody, when you start your program, it takes a few weeks to get a flow going with you and your APP and just the room and just how you're going to work it. But we realized that for us, we realized it worked best for the PAC to initiate all the questions. We complete all of the forms, and then take the patient actually to a separate room for the nurse practitioner to see those patients. And then we go back and build the eCare plan and make sure that it has the appropriate resources on it. And then we go and hand that back into the nurse practitioner as she is finishing her evaluation of the patient, and then she goes over it with them. So that's just kind of the routine and flow that we were able to come up with to save time and make sure that we were able to see as many patients as quickly as possible. Some of the successes that we've seen with Compass is patients are definitely contacting us with questions and concerns. One thing that we found that we would never have known without doing this Compass program is that a lot of our rehab was getting ordered at discharge, but it was a long delay before it's actually getting initiated. And especially that was a huge concern with our speech therapists in this area, and I think in most areas, there's very few speech therapists around, and their schedules tend to get very backlogged. And we found out some of our patients were being discharged on, honey-thickened liquids, very aphasic, but could move and didn't really need inpatient rehab. They were safe to be home with family, but absolutely needed speech therapy to start quickly, and they were waiting 2 and 3 weeks for their speech therapy to get initiated. So we were able to meet with our inpatient and outpatient home health and rehab departments and working on better ways that we can identify really high-risk patients, making sure they have the resources and contacts that they need, and kind of prioritizing them a little bit better. They're calling us about questions about medications, outpatient testing, just making sure that they understand all of their follow-up. We've actually seen, which is an interesting correlation, our stroke unit is our 4 West unit, neuroscience unit, and their patient satisfaction surveys have actually improved right at the October span. You can see from October on when we started our program here with Compass. So the manager of the unit is definitely correlating that this program is just with the multiple patient contacts, that the surveys they do after discharge are getting higher and better ratings because of the Compass program. We went over it, and that's about it. So any questions, please feel free to contact me, and hopefully I didn't go over that too quickly so that you could get some good information.
Thank you so much, Melissa. That was extremely helpful. And is there anything burning for Melissa before we move on to Whitney? Okay, well, it's quiet out there, and we will have time at the end for discussion. So I'm going to ask Rika, and it looks like she's already pulled up Whitney Arrington's presentation from Fry Regional Medical Center. And Whitney, you should have control by now, and we'll just ask for you to carry on with your presentation.
Okay, great. So my name's Whitney. I am the PAC here at Fry Regional. I'm also the stroke coordinator and the director of our inpatient stroke unit. So all things involved in stroke kind of comes back to me at this point. So it's been really a great opportunity for me to kind of see how that process moves along and how it really impacts our stroke systems of care here at Fry. So our initial process, of course, was not unique in the fact that we really needed to carve out and figure out who was going to be the best fit to be our PAC and our APP. Our hospital in itself does not own a neurology clinic. However, we're very fortunate in the fact that we work closely with one of the 2 neurology clinics here in town, and one of the neurologists is actually our stroke director. So we identified that the best fit for the APP was going to be his actual PA at the office who works under him. And then myself as the PAC, just solely for the fact of it, really just being someone who's knowledgeable in the process and kind of carve out that time each day. So that's kind of a two-edged sword because I do wear a few different hats. We wanted to make sure that we had a consistent process for myself, for the APP, and also, most importantly, for the patients to be consistent and make sure that we had enough time and enough slots available each week to be able to see these patients within that 7 to 14-day window that we have. For us, the best workflow that we could create was that, and it sounds like some of the other hospitals are now doing as well, or have been doing, is dedicating a day or, more if needed, of the week in which we could see these patients. So that way, I know every week that on Friday mornings I go to clinic, and that way I don't have to run interference with any of the other responsibilities during that time, and the same thing for that APP. So we actually see all of our TIA stroke patients who are included in the Compass study. Every Friday morning we start at 7 a.m. and go until about 12:30. And we find that with our number of patients that are discharged and eligible for the study, that this provides enough time, and most of our patients are actually seen within 7 days. So that's been a success for us, and I'll talk a little bit about that in another slide. But then again, we were also fortunate in the fact that we were able to carry out the Compass model as it was outlined. So I'm actually the patient's point of contact before they leave the hospital. I make the 2-day phone call, see them in clinic, and then also make those 30 and 60-day phone calls as well. So that really has enabled me to build a rapport with these patients and continue that post-discharge as well. And so then I'll talk a little bit about how we track our TIA and stroke patients each day on the next slide. So what works well for us, some of our biggest successes, of course, are that myself and the APP, we're aligned with the same goals as the study is to provide the best outcomes for the patients. We both want to make sure that we're aligning with the study and making sure that it's exactly as it's outlined, we're able to follow that. And so for us, that, you know, really meant us sitting down, talking about our workflow and who was going to do what to enable the best patient experience. And so, like I talked about, I'm actually able to execute every step of the Compass model. And I feel like, you know, for the patients when they leave the hospital, it automatically increases their comfort level because they know they're going to talk to me on the phone. I'm actually going to be there with them at that appointment, and it improves that relationship. So if they do need to call me with questions, or I need to call them, you know, it really makes them feel comfortable and feel like they have somebody that they know that they can link back into our system with. I already talked a little bit about the dedicated times for clinic, but for us, you know, it just was a time that we knew was not going to be interrupted, that would allow a complete focus on the Compass patients and the study itself. Along with that, we wanted to make sure, you know, that we were providing the patient with every opportunity to understand and hear when that appointment was going to be, to talk to their caregiver, hopefully at some point throughout, whether it be before they're discharged from the hospital, at the 2-day phone call, or whenever the neurology clinic itself makes that appointment reminder. So they have a variability of different times in which they can hear when that appointment is going to be and confirm that, and have the opportunity to reschedule if they need to. Our workflow, we, at this point, I feel like have a very efficient process. Roger Alston is our APP, and he and I work very well together to make sure that the patients are moving through. It's efficient for us and also the patient, because they, we find that whenever the patient's discharged, of course, they have hopefully a primary care provider follow-up that we're trying to make within 7 days, our appointment, and then, you know, numerous other appointments maybe. So we want to make sure that we're, you know, valuing the patient's time as well. And then, like I said, just 1/2 a day a week. So we are able to get in 4 to 5 appointments during that time, allows all of our patients to be seen within 14 days. So the other thing that was initially kind of a barrier for us and something that we had to work through pretty quickly was finding a way in which we could identify those patients every day, to make sure that we are capturing the whole population and not leaving anybody out of the study. So I work very closely with our clinical informatics team to actually build a report that gets pulled out of our charting system, which is Cerner, every day. It pulls out all the codes that would be included for the Compass patient. So all the discharge diagnosis codes, which for our physicians, they actually key that in on admission and kind of work through that throughout the patient's day. And so that list actually gets emailed to me every day. And those include patients who are in the emergency department as well. That way we're capturing that population. For me, I had a little bit of heartburn when we started that I might be missing some of those TIAs that are infrequently discharged from the ER, but it does happen. So this reporting system allows for me to capture those as well, which has been very beneficial throughout our process. Achieving enrollment, for me, I found that one of the biggest things whenever you're going in and you're making that first visit with the patient, which is hopefully before they're discharged, is the proper scripting, how to present this in a way that it excites the patient as much as it excites us to be able to deliver that care. And a big piece of that was kind of going through the study myself and, you know, picking apart the pieces that would appeal to the patient the most, and also being able to present it in a way in which they didn't really feel like, okay, this is just another clinical trial, because we do have patients who come in and they're, you know, very deterred from that because maybe they've been through it before, or maybe they kind of got wrapped up in something that they didn't understand all the components to. So for me, when I go in, I always make an effort to sit down with them at the bedside so that I don't feel rushed in talking to them or make them feel like I'm trying to sell something to them. I'm very honest with the patients. I let them know that really this is a standard of care that we've adopted for our whole hospital. So it's not only certain patients, it's our whole stroke population. And one thing that I find, patients have a lot of apprehension about at times, but are sometimes afraid to ask, is about a cost. Patients oftentimes are working on fixed incomes, or they maybe feel like they're not going to have the money necessary to provide, to be able to go through the study. And so being able to talk about that and kind of letting them know that really this is not any extra associated cost any more than what we would expect for the patient if they followed up and weren't in the program, I find puts them at instant ease. They understand that it's not really something that we're trying to gain extra dollars for. It's really for their benefit. So also for us here in the Hickory area, Fry is known as a huge cardiology hospital. So it's, for me, trying to link back in some of those patients, I have to use other disease processes. I let them know this is the same thing. If you had a heart attack, we would want you to follow up with a cardiologist. You wouldn't just be let loose back out into the public and not have any follow-up in that aspect. So a stroke is really no different. You've had a stroke. Now you need to, follow up with neurology. And so for most patients, that kind of helps them. It helps it click. It helps it tie back into other things that they maybe have been through in the past. And so just being able to use different examples to help them understand real-life scenarios of why this is so important to get them back to that clinic visit. And then, of course, allowing time to ask questions and provide feedback, helping them work through any questions they may have or any thing that may make them feel like they don't want to participate in the study, and helping them to see all the benefits usually helps me get the patients on board and actually get them excited about the follow-up program. Barriers. So, of course, wearing a lot of different hats, it was very important for me to find the consistent time to dedicate for follow-up phone calls. And I know most of you wear other, or do other roles or wear other hats within your setting as well. So, I feel like I owed this to the patients. If we're going to participate in the study, we needed to make sure that we were doing it as it was outlined to provide the full experience for the patient. So what I do is every morning when I come in, the first thing that I do is look at my email list, go ahead and get a head start on those phone calls for the day. That way I'm not left, ready to walk out the door in the evening and then think, oh goodness, I haven't called my COMPASS patients, or I haven't made that initial contact with them. So that way that's the first thing that I get done throughout my day. Resources for our backup APP and PAC was a little bit challenging for us. We're a medium-sized hospital, but really in the stroke realm itself, I'm pretty much the only person that's dedicated in that role. So we had to think a little bit outside the box as well, just like Mission did, and actually we're able to use our dedicated stroke unit has a charge nurse that's not in staffing. So she actually has been able to train with me and is now serving as the backup PAC whenever I'm not here. So, and then in the neurology office, they're very fortunate to have 3 or 4 different PAs, so they're able to use them as their backup APPs should Roger not be in the office. Same thing as far as weekends, holidays, and after hours, being able to kind of link back in those people that you do have here. So being able to have a close-knit relationship with the nurses on the stroke unit helps me to loop them in and understand how important it is to kind of start talking about the COMPASS study even on the weekends and distributing the folder to kind of plant that seed so that the patient knows on Monday morning they should be expecting a phone call from me. I find that really helps for patients to become aware that this is, kind of the standard and to be expecting to hear from me. And then, of course, like I said, talking about those patients who are infrequently discharged from the emergency department, but it does happen as far as some of our TIA patients, to be able to capture those, because I found that usually those patients are the ones that they need this model the most. They haven't been admitted or been in the observation unit for at least a observation time or a workup. So they actually end up being some of the patients that they need the most resources whenever they come to our 7 to 14-day follow-up visit. For me, I think our best successes so far in the COMPASS model has been our efficiency. Myself and the APP have a great working relationship. We're able to be very efficient when we're in the office, in clinic, to see the most patients possible, but to make the appointment very meaningful for the patient, make sure that we're covering what we need to cover and close any loops, maybe from the hospital visit. We are able to carry out the model as it was designed, so I feel like that's a huge advantage for us because we can really see how those relationships that progress are so meaningful to the patients and make them feel at ease during their recovery process. And then it's a great opportunity for me because I'm kind of involved every step of the way as a stroke coordinator, as a director of the inpatient stroke unit, to see where our gaps are and where we're also what our strengths are. So, you know, there's things that we found out as far as our outpatient rehab program that a lot of patients are linked back into, making that process more efficient, helping patients get in sooner, and then also helping to identify those resources that we never really knew existed out within our community. And then, of course, our best success, I feel like, is being able to support those patient outcomes. So moving patients through that recovery process and helping them understand that they have people who are on their side and people who are dedicated to making sure that their recovery is everything that it should be. So that's all I have. If you have any questions, feel free to email me and or chat with me during the question session.